Hello everyone and welcome to our module on pulmonary embolism. This is a CT angiogram, a type of CAT scan from a patient with a pulmonary embolism. This is a slice through the chest. The large black areas on both sides of the image are the lungs, and in the middle of the picture there are white structures. The reason they are white is because contrast dye has been injected into the venous system. So this white structure I'm marking with my pen is the pulmonary artery. Within the pulmonary artery, you can see these dark spots right here. That is thrombus lodged in the pulmonary artery, and that is evidence of a pulmonary embolism. Here I've zoomed in on the picture. You can see that this is a large pulmonary embolism that crosses the bifurcation of the pulmonary artery. These types of pulmonary emboli are called saddle emboli because they sit like a saddle across the bifurcation of the pulmonary artery. This is a life-threatening condition, and the patient who has this pulmonary embolism is likely to be in shock. A pulmonary embolism is a thrombus in the pulmonary artery, just like we saw in that CAT scan. Rarely do these thrombi form in the heart or the pulmonary vasculature. They almost always come from the femoral vein or another deep vein in the leg. We'll talk more about this in a little bit. They then embolize to the lungs, and that's why they're called a pulmonary embolism. They travel to the lungs via the inferior vena cava to the right atrium to the right ventricle, and finally they wedge into the pulmonary arteries. Sometimes pulmonary emboli are spontaneous or so-called unprovoked pulmonary emboli, but you should be aware that often they are secondary to some hypercoagulable state. I discuss hypercoagulable states in detail in the hematology section, but just by way of review, there are hypercoagulable states that are secondary to another condition like malignancy or surgery. There are also primary hypercoagulable states which are defects in the clotting system. These are things like protein CNS deficiency or an antithrombin 3 deficiency or many other conditions. The main clinical features of pulmonary embolism are chest pain and respiratory distress. The chest pain of pulmonary embolism is classically pleuritic, meaning it is worse with a deep breath, although in actual practice, the chest pain presentation in PE can be highly variable. In addition, many patients have respiratory distress, including complaints like dyspnea. They may also have hypoxemia and tachypnea. Once again, though, there's a great variation in actual practice. Some patients with pulmonary embolism are not hypoxemic, so you can't rely on a normal oxygen level to exclude pulmonary embolism. And then finally, a massive pulmonary embolism like the one we saw in that CAT scan earlier in this video can cause sudden death. The reason for this is because the embolism is so large it obstructs flow through the pulmonary arteries. So there's a tie-in here with blood flow mechanics. The pulmonary vascular resistance gets very high in massive PE, and that leads to right heart failure, and it can lead to a low cardiac output and sudden death. Patients who have multiple small chronic emboli can sometimes develop pulmonary hypertension. And once again, what's happening is the pulmonary vascular resistance is going up from multiple pulmonary emboli, and that leads to pulmonary hypertension and can potentially lead to right heart failure over time. Let's talk about ventilation and perfusion in patients with pulmonary embolism. This is super high yield because it's a tie-in between a very common disorder, pulmonary embolism, and basic concepts of pulmonary physiology. In pulmonary embolism, you have obstruction to blood flow, so you're going to have a lack of perfusion in areas of the lung that are still ventilated, and when this happens, this is called dead space. And I talk about dead space in other videos in pulmonary physiology. In addition to dead space, you're going to develop VQ mismatch. Portions of the lung are going to have blood flow that is not matched to ventilation, and VQ mismatch is one of the classic causes of hypoxemia. So a low oxygen level in the blood can develop from VQ mismatch, and you should always remember this. It's super high yield to know VQ mismatch is part of pulmonary embolism. Because of the hypoxemia, patients with pulmonary embolism often hyperventilate, and this can lead to a low PCO2. Now, in reality, blood gas findings in PE are highly variable, but for your step 1 exam, you want to know that the classic findings in pulmonary embolism are a low PaO2 and a low PCO2 in blood gas. Just to make this very clear, what happens in pulmonary embolism is you have VQ mismatch causing hypoxemia, meaning a low oxygen content in the blood. This causes patients to raise their respiratory rate, in other words, to hyperventilate. The hyperventilation causes the CO2 level to go down, so patients will have a low CO2 level. So the classic findings in pulmonary embolism on blood gas are hypoxemia, a high respiratory rate, and a low CO2. Closely related with the condition of pulmonary embolism is the condition deep vein thrombosis. This is a thrombus that forms in the deep veins of the leg. Usually it's one of the veins in the calf or the thigh. Commonly, it is the femoral vein, which runs through the thigh. Sometimes it is the popliteal vein, which runs behind the knee. It can also occasionally involve other veins. The reason that deep vein thrombosis is closely related to pulmonary embolism is because deep vein thromboses can grow and extend up towards the heart, and pieces of the DVT can break off and travel to the lungs, and this can cause a pulmonary embolism. And just like pulmonary embolism, deep vein thrombosis is often secondary to a hypercoagulable state, although sometimes they are spontaneous or unprovoked. Many deep vein thromboses are asymptomatic, and for this reason, patients are unaware they have a blood clot in the leg until a piece breaks off and travels to the lungs and causes a pulmonary embolism. When they are symptomatic, they can cause pain in the calf. Sometimes you can feel a palpable cord on the back of the leg. This is from a thrombosed vein. They can potentially cause unilateral edema from poor venous outflow from the leg. Sometimes they lead to warmth, tenderness, and erythema in the calf or the thigh. There is a physical exam sign called Homan's sign, which is suggestive of a deep vein thrombosis. This is pain in the calf when the patient dorsiflex the foot. And the diagnosis is usually made by lower extremity ultrasound. This is a picture of a lower extremity ultrasound shown on the screen here. Shown in the middle of the image is the femoral vein, and in the middle of that femoral vein there is a clot. The reason we're talking about deep vein thrombosis in the pulmonary embolism video is because deep vein thrombosis has similar causes and also similar treatment to PE. In fact, the two disorders are often referred to together as DVT/PE or as venous thromboembolism or VTE. Prevention of deep vein thrombosis is particularly important in hospitalized patients, and you will see this frequently on your clinical rotations. Patients who are hospitalized have hypercoagulable states in many cases. They are often immobile, and therefore there is stasis of blood. In addition, they often have ongoing inflammation, which leads to a hypercoagulable state. So for all these reasons, the incidence of DVT is very high among patients who are hospitalized. So prophylaxis is often administered with shots of subcutaneous heparin or low molecular weight heparin to decrease the risk of developing a DVT while the patient is in the hospital. There is a special device that is sometimes used in treating patients who have deep vein thromboses, and that's called an IVC filter. This is used in patients who are very high risk for DVTs and in whom you think the deep vein thrombosis might break off and cause a pulmonary embolism. A filter, such as the one shown on the screen, is inserted into the inferior vena cava. This prevents pieces of DVTs that form from breaking off and causing pulmonary embolism. In patients who have a massive pulmonary embolism, there is a classic EKG finding you should be aware of. It's called the S1Q3T3. If you look at this ECG tracing on the screen, you can see that there is a deep S wave in lead 1 here at the top left of the tracing. You can also see that in lead 3 there is a Q wave present. There's also an inverted T wave. This is called an S1Q3T3. It's a sign of right heart strain, and it can be seen in patients who have massive pulmonary embolism. On this slide, I've zoomed in on the key features of the S1Q3T3. In lead 1, you can see that there is a deep S wave. In lead 3, you can see that there is a Q wave and also an inverted T wave. In addition, patients with an S1Q3T3 typically have a pseudo right bundle branch block in lead V1. You can see that the QRS complex in lead V1 is somewhat widened here. I've shown you a normal QRS complex below just for comparison. In clinical practice, especially in the emergency room, there is a scoring system called the Wells score that is often used to estimate a patient's probability of having a deep vein thrombosis or a pulmonary embolism. Many patients present to the ER with shortness of breath, and pulmonary embolism is always in the differential, so deciding which patients are high probability and which are low is very helpful, and the Wells score can be used for this purpose. So the Wells score assigns a point for any of these items shown on the screen here. You subtract 2 points if an alternative diagnosis to pulmonary embolism is likely, and a score of greater than or equal to 3 means a high probability patient, a 0 score means a low probability patient, and 1 or 2 are in the middle. And as I said before, this is often used in the emergency room to determine which patients need a CT angiogram for potential diagnosis of a PE. There is a blood test that is sometimes used in making the diagnosis of DVT or PE, and that is measurement of the plasma D-dimer level. The D-dimer is a degradation product of fibrin. I talk about this in the hematology video on the coagulation system. When blood clots are present in the body and being broken down by the coagulation system, that will raise the serum D-dimer level. For this reason, the finding of an increased D-dimer level in the plasma is a sensitive but not specific test for DVT or PE. Because it's sensitive but not specific, it's called a unidirectional test. Levels of the D-dimer in the plasma are elevated in the setting of DVT or PE. However, they are also elevated in many, many other conditions. For this reason, its greatest value is when the level of the D-dimer in the serum is normal or not increased. This argues strongly against the diagnosis of DVT or PE. For this reason, measuring the D-dimer level is often helpful in patients with a low to moderate Wells score. When you have a low to moderate Wells score coupled with a normal D-dimer level, that argues strongly against the diagnosis of DVT or PE. In the modern era, the diagnosis is usually made via a CT angiogram like the image I showed you at the beginning of this video. There's another test that is sometimes used called a VQ scan. This is a nuclear medicine test. Patient inhales a gas with a nuclear tracer in it, and this shows you which portions of the lung are being ventilated. That's what's shown in this image on the left side of the screen. A nuclear tracer is then injected into the bloodstream, and this shows you which sections of the lung are being perfused. And you can see in this image that there are parts of this lung that have poor perfusion by the nuclear tracer. This suggests a blood clot is limiting the blood flow to those regions. In general, the treatment of deep vein thrombosis and pulmonary embolism is with anticoagulants. I talk about all these drugs in the hematology section. Initially, treatment is usually begun with heparin or low molecular weight heparin. These drugs are rapid acting. Patients are then transitioned over to oral therapy with warfarin. And in the case of a massive pulmonary embolism, especially in patients with shock, sometimes thrombolysis with tissue plasminogen activator is used. About 25% of adults have a patent foramen ovale. This occurs due to failure of the foramen ovale to close after birth, and this can potentially allow a venous clot to reach the arterial system. In particular, a venous clot can potentially reach the brain, and rarely patients who have a patent foramen ovale can develop stroke in the setting of a venous thromboembolic disorder like DVT or PE. Shown on the screen is an echocardiogram image of a patent foramen ovale. This is the right atrium on the left side of the image. This is the left atrium over here. You can see that there's a flap of tissue and a space through which blood can pass. This space is the patent foramen ovale, and it can potentially allow a clot, which is in the venous side of the body, to cross over to the arterial side. I'll finish this module by talking about some other embolic disorders that can potentially involve the lungs, and we'll begin by discussing fat embolism. A fat embolism classically occurs after a long bone fracture. There's fat found in your bone marrow, and in the setting of a long bone fracture, it can be released into the venous system. Importantly, fat may cross the lungs, and this can potentially lead to small artery infarctions on the arterial side of the body. So patients who develop a fat embolism often have what's known as the fat embolism syndrome, where they develop a characteristic triad of symptoms that involve the pulmonary system, the central nervous system, and the skin. In the lungs, patients typically develop respiratory failure. They will complain of dyspnea and develop hypoxemia. There is often diffuse capillary leak, which can look similar to ARDS, and these patients often require mechanical ventilation. In the neurological system, there is usually confusion, and potentially patients can develop focal neurologic deficits. And on the skin, classically patients develop petechiae. This is a picture of a patient who has petechiae and purpura on their ankle. So the way this is going to be presented in a board question is a patient with a fracture after trauma who develops respiratory failure and confusion and also petechiae. That is the fat embolism syndrome. An amniotic fluid embolism develops during labor or shortly after. In this condition, amniotic fluid or fetal cells or other fetal debris enter the maternal circulation, and they lead to a widespread inflammatory reaction. This is often fatal. It's one of the causes of death following childbirth. The symptoms are often divided into two phases. The phase 1 symptoms develop from pulmonary artery vasospasm. This leads to pulmonary hypertension and right heart failure. The patient can develop hypoxia. There can also be myocardial capillary damage, which leads to left heart failure, and pulmonary capillary damage, which leads to ARDS, which is the acute respiratory distress syndrome. So the way this will present in a board question is a woman shortly after delivering a baby who develops respiratory distress, hypoxemia, and hypotension. Phase 2 is sometimes called the hemorrhagic phase. In this phase, the mother develops massive bleeding and disseminated intravascular coagulation. The key feature of this phase is obviously bleeding, and in addition, seizures can be seen in either phase 1 or phase 2 as a component of amniotic fluid embolism. And that concludes our module on pulmonary embolism.